مساء الخير، أهلا بكم في محاضرة هذا المساء، وهي مقدمة من الدكتور سداد التميمي Senior Consultant Psychiatrist in UK. عنوان اليوم المحاضرة هو Clinical Ethics in Psychiatry. تفضل دكتور سداد.
مساء الخير. Good evening. I think the subject of clinical ethics in psychiatry is not probably the most interesting of subject to listen to or to talk about, but nevertheless, it is extremely important in clinical practice and something probably a lot of us are not aware of it till they start to practice psychiatry in real life. Probably, if we look about what is the agenda when we talk about ethics in clinical psychiatry. I mean, first of all, we think about ethical dilemmas that will face the psychiatrist every day. There are also some challenges and limitations to the ethical models available. There are so many ethical models, and all of them have their own limitations and own challenges. Also, the big question we ask, do we have ethics committee where we practice? Now, most of the time, people associate ethical committee with research. So whenever you want to do a research, you have to apply to the ethical committee. Then if they don't like what you are doing, they will come and ask you, interrogate you, and so on. But also, everywhere you go, you have to be aware of the legal challenges you might face, especially in dealing with patients with mental health problems. Okay. Now, so the first part of the talk today will be about ethical models. I think we need to refresh our memories and our knowledge about these models and their origin. Basically, what is ethics? It's a moral philosophy, a discipline concerned with what is good and what is bad, and morally right or wrong. That's what it is, really. There is nothing strange about what is ethics, what is good, what is wrong, and what is good, what is bad, and so on. Its philosophy probably penetrates all aspects of our life. Now, what are the moral conflicts of psychiatry origins? I mean, psychiatry faced a lot of moral issues, and every now and then you will hear about them. First of all, the asylums, mental hospitals, the big asylums that people have. Probably everyone have seen so many films that will touch on that subject. And people used to call them custodial warehouses. The second part that will face the moral complex in psychiatry, the issues about the transference relationships. These are quite common in psychiatry, not only apply to psychiatrists, by the way. They apply to psychologists, mental health nurses, mental health workers. Okay. Still, we have some issues with regard to physical treatments, with regard, leucotomy. I know it has almost disappeared, but still a practice. Insulin coma, nobody will do that anymore. But still, we do have issues with regard to ECT, for example. Okay, a lot of people will question the validity of these physical treatment in psychiatry. And of course, people always remind others that psychiatry was exploited by the Communist Party in the Soviet era. And you could see here, this is a picture of Whitchurch Hospital in Cardiff. And those are pictures of the consultants who were working there at the time when it's closed. We were all invited to that ceremony. Okay. Now, what are the origins of the ethical codes? I mean, first of all, there is the Code of Hammurabi, the Ten Commandments, the Dialogue Protagoras by Plato, the divine origins. In all holy books, there are issues related to ethical practice. What we have to keep in mind that ethical issues It's not really only something that we can cognitively manipulate or process. Emotions are strongly involved in all our moral judgment. Yes, you have to make a judgment using the left side of your brain, the left hemisphere, but frankly, your judgment is always affected by the functions of the right non-dominant hemisphere that we use. And this is why when people really become judges, okay, you find them, they have exceptional quality in being able to process information without their emotional, without any emotional interference from the right side of the brain. And this is, of course, a universal issue. It's not related to the West or East, North or South. Now, the first theory that you are all aware of is that of Aristotle, and that is the virtue theory. Basically, what it says is that a person's character is at the heart of moral deliberation. And the prerequisite to living an ethical life is developing character traits that promote virtuous behavior. You work for the common good. So you notice what is going on, what are your expectations, you put a value to it, you feel it, then you have a desire to choose and act and react. Now, this is the first theory, the virtue theory. Then the one that really proliferated in the West during the Industrial Revolution is that the philosophy of Immanuel Kant. And this is what is referred to as deontological theory. Basically, what he is saying is that the right moral action is justified by the person's intrinsic value. We do the right thing because we have a moral obligation to do so. It's a moral obligation, not because of an extrinsic motivation. This is really in real life. It is, even if we judge somebody outside, we judge him really by his moral obligation to do something good rather than extrinsic motivation like to make money or to manipulate people and so on. Then there was the theory of John Mill, and that is the theory of utilitarianism, and the act is morally right if it is compared with alternative act. It yields the greatest possible balance of good consequences. So here we have the balance of probabilities. Okay, it's probable that what I am doing is right, I will do it. Okay, you can't be certain. You can always make a mistake, but you have to make a moral judgment on the balance of probability. And this is something used in court, in civil courts. Okay, in civil court, you judge by the evidence. It's the evidence, the probability, you see. You will say, probably this is right, this is wrong. While in criminal court, no, you can't rely on that. You have to have an evidence beyond any reasonable doubt. Okay. And you can see that, for example, with what's happening in the United States with Trump at the moment. Is he going to be judged on the balance of probabilities or beyond any reasonable doubt? Now, but the one that is most important for medical practice is what we refer to is the principlism and the quadrant of principles of ethical reasoning by Brucham. You have to respect patient's autonomy, self-government, maximize welfare of the patient, you minimize harm, and treating people fairly. You respect justice principle. Now, this is the principles that we learn and we practice in medicine, not only in psychiatry. So you respect the patient's autonomy, you maximize welfare, minimize harm, and you respect justice principle. So this is just the beginning about the moral issues, okay? And it's nice sometimes to review them, okay? I mean, not only in our clinical practice, and probably what we do in real life as well. But what about current psychiatric practice and ethics? Now, you find, I mean, people when they graduate from medical school. I mean, the first thing they do is that they swear that they will use my power to help the sick to the best of my ability and judgment. I will abstain from harming or wrongdoing any man by it. So basically, you are given the power as a doctor. Use it morally, use it properly. Do not make any harm, okay? I mean, this is why people always say, first, do no harm, okay? But sometimes you have to be careful, is that you first do no harm, and then you don't do any good, okay? Because you are worried that because of the Hippocratic Oath, I will stick to that principle. Sometimes, yes, we, like people when they decide on surgery, for example, when we decide on giving somebody ECT, you know, because they are going to die because of their depression. Now, modern day ethics in clinical practice psychiatry really relies on the Thomas Percival modern day ethics, medical ethics or code of institutes and percept, and was adopted to the professional conduct of physicians and surgeons in 1803. But then, let's, jump to what is happening now. I mean, we have the Royal College of Psychiatrists. To us as psychiatrists, they produce their code of ethics for the Royal College of Psychiatrists. And I will challenge you that probably 90% of psychiatrists don't read it, okay? Despite the fact it's very, very, very important. Now, there are 12 codes that people have to stick to. First of all, psychiatrists shall respect the essential humanity and dignity of every patient. Don't exploit patients' vulnerability, because what we, in psychiatry, all your patients are vulnerable. Frankly, any patient is vulnerable when he is physically unwell or mentally unwell. You provide the best attainable psychiatric care for your patients. You maintain the confidentiality of patients and their families, okay? Then you seek valid consent from your patient before undertaking any procedure or treatment. Remember here, I mean, you focus on the issue of valid consent. This is what we're going to touch on later, the conflicts that we face in psychiatry. Psychiatrists shall ensure patients and their carers can make the best available choices about treatment. Don't misuse their professional knowledge and skills. Comply with the ethical principles embodied in national and international guidelines governing research. This is what you have to do. And then you have to continue to develop, maintain, and share your knowledge with your peers and with your juniors. Have a duty to attend to the mental health and well-being of your colleagues, okay? It's not only your patient. If you notice that your colleagues are suffering, or maybe that is affecting their practice, you have to duty to inform your superiors about them. You maintain the integrity of the medical profession and shall work to improve mental health services and promote community awareness of mental illness and treatment and prevention. And this is frankly to reduce stigmatization. This is the code of ethics that the Royal College of Psychiatrists have produced, and every psychiatrist in the United Kingdom has to stick to. But they do have a lot of limitations themselves. Now, what are then the conflicts in psychiatry we face? Now, privacy and confidentiality, but sharing information. I mean, sometimes you are faced with the issue of sharing information with the police when your patient, for example, commit a criminal act. Issues of child abuse, okay? Now your patient will tell you that she has been abused by so and so on. You have the duty, frankly, to inform the police. You cannot deal with legal issues. That's something the legal profession will deal with. Suicidality. Patient is telling you, I'm going to kill myself, I'm planning that and that. Okay. Yes, he has full consent. Should you inform his family? Should you inform his GP? Should you inform, the teachers if they are teenagers? Then there are issues of dangerousness, okay? What do you do with a patient who has delusional jealousy, okay? Now, what about patients with erotomania? And both those two are quite dangerous, all right? You have the duty, for example, to inform the wife, like your husband is suspicious, he's planning to do so on. So now, but most of the time, what do? We pass that responsibility to social services. So you see, this is the issue with the privacy or confidentiality. Probably you don't get it anywhere else. Just imagine a patient attending to you and he has delusional jealousy, and then you are faced with that dilemma of informing his partner. Maintaining boundaries. Now, psychiatrists are the worst at that. Boundary crossing and boundary violations. You know, there are certain boundaries. I mean, for example, should you go and sit down with your patient and have a cup of coffee in a cafe and have a chat? That you might call it boundary crossing. But would you go, for example, and with your patient to the cinema? You know, that's a boundary violation. There was a case actually of a psychiatrist, you know, in private practice, trying to help his patient who suffers from eating disorder borderline. And he goes with her swimming. Now, would you agree that this is not boundary crossing? Frankly, this is boundary violations, for example. And this is, by the way, doesn't apply only to psychiatrists. Psychologists as well, they do that. Will you give them your telephone number? That's another issue. Will you let them contact you on Messenger or on, you know, WhatsApp or what is it? All right? How do you maintain the boundaries? Very, very important. Then you have to be careful about the cultural and individual sensitivity. I mean, for example, in psychiatry, you come across people, for example, of different cultural background, like people from Afghanistan, people from, you know, the East, you know, they have certain values. You know, there is the issues, for example, with regard to the shame and, you know, some issues, for example, it happens a lot with the Arab community here, and especially from different parts of the Arab world. But there is also the issues here related to, for example, some groups like Jehovah's Witness, okay? You have to be respectful of their cultural sensitivity, okay? And very individual. And if you are in doubt, you have to consult with your colleagues about it. But then the professionalism. Now, professionalism, you exhibit in honesty, integrity in your interaction with the patient. As with other medical specialties, psychiatrists must be honest, give complete information to the patient in order to facilitate understanding and education. Now, how many of us can do that? How much can you tell them? What do you tell to a patient who suffers from psychosis? What do you tell the patient who is manic, for example, right? Now, you facilitate understanding and education. Yes, maybe it depends on the time you see them, their mental state. And you see, this is the difficulties that that the psychiatrist would face compared to other medical professions. And this is what brings us to part 3 of the talk, psychiatrists and the law. Of course, I am going to talk about the law as I understand it here in the United Kingdom, but I don't think it is really much different from the law, for example, in Jordan or in Iraq with regard to the clinical practice. And I think Dr. Walid really advised me about the issues with regard to the family interference and getting family consent in dealing with compulsory admission in Jordan that I wasn't aware of. I mean, the United Kingdom, you know, they don't have, you know, a constitution. They have the law. It is embodied in the Magna Carta since 1215. And actually, this is a picture of Salisbury Cathedral. It is one of the most beautiful cities in the United Kingdom on the south coast. And here, actually, this is the Salisbury Cathedral. It is one of the most wonderful places. This is where the Magna Carta is installed. So they have that the law is above everybody. And you find that the law in the United Kingdom changes. For example, you have to, I mean, if a judgment is made about a certain issue, becomes embodied as a law, okay? You know, they don't have a written constitution like in other countries. So the judges are the one that will make a constitution which is dynamic and changes. You have to keep up with it. For example, a judge will decide whether about issues with regard to capacity, about certain conflicts between the psychiatrist and their patient. This has come up regularly. And you could see here that we have the Mental Health Act manual, okay? There is an edition every year, every 6 months sometime, and you find it increasing in volume every year, okay? Why? Because there is a judgment, okay, of a certain judge, of a case between a health authority and patient, okay? And that will become embodied in the Mental Health Act manual. We call it the Mental Health Act 1984. It was revised in 2007. And of course, it has changed a lot of things. You know, one of the things, for example, that has changed 2007, the introduction of what's called mental disorder. While before we used to talk about mental illness, and I'm sure Dr. WALID, Dr. Nazar are aware of that. Before it used to be the word mental illness. That has disappeared, replaced by mental disorder. And this is by the Parliament, of course. Okay, so the Parliament will pass the act, but the judgment all will be made by judges at a later date. So that's one thing we have to be aware of every day. The second one is the code of practice that you have to carry with you. According to the act, how do you practice? Now, so the guiding principles here, also, you find the volume of the code of practice used to be a very thin book. Now it's a textbook, okay? And you find that there are guiding principles. Basically, you have to least restrictive option and you maximize independence of your patient, especially if they are detained against their will. Empowerment and involvement of the patient, your respect and dignity, purpose and effectiveness, efficiency and equity. Okay. Now so every time you face a conflict about a patient with regard to legal issue, you refer to the code of practice. But then we have another act, which is considered by far the worst act in the British legal system, and this is the Mental Capacity Act of 2005, which is referred to as deprivation of liberty. It is separate from the mental health. This is deprivation of liberty. When you decide that the patient lacks consent, you can't deprive them of their liberty. For example, I will give you an example. I mean, last month, actually, I had a patient who is manic depressive, and you know, he has chronic obstructive pulmonary disease. So we have to take him to the general hospital, but he doesn't stop smoking, and he wants to go out, take off his oxygen, go out to the garden and smoke and so on. So the best way of doing it is to deprive him of his liberty. But how did we do that? We used the emergency deprivation of liberty. Now, to do the proper deprivation of liberty, to enforce it, which will take a couple of weeks, you have to have an assessor that the social worker will come and assess it. It is a very lengthy procedure, but you have an emergency. You know, you can use the emergency, you know, buying your time till the patient gets better. I mean, I know this is naughty, we shouldn't do that, but frankly, we have to do that with that particular patient. So let's do some case studies to review these conflicts that we face in psychiatry. I mean, the first one is capacity, okay? القدرة العقلية. Now, let's take the example of this patient. Mr. V is a 65-year-old, suffered from schizophrenia, being detained in a locked rehabilitation unit. And he suffered from backache with poor response to palliative measure prescribed by his general practitioner. Now, his health suddenly deteriorated. One day, he started to come. He doesn't let his GP examine him. The GP asks him, oh, do you want to go for an X-ray? He says, no, right? Anyway, his health suddenly deteriorated. And actually, it was my case, you know. And he let me examine him. I sent him immediately to the hospital. There was suspicion that there is something more than just a backache, as the GP suspected. And the hospital, they diagnosed with multiple myeloma. Okay, it was diagnosed rather very, very quickly. Now, he was over radiotherapy or chemotherapy. Now, the physician concluded that he is capacitated and he's refusing treatment. However, it's not only my view, because he's my patient. I have to ask somebody else to assess his capacity. The capacity, psychiatrists view know that Mr. V lacks capacity because that's interfering with his judgment. His mental illness interferes with his judgment. Okay. Now, mental capacity is normally defined by a person's ability to make decisions for themselves. At a time, a decision needs to be made. Okay. So it is time specific. You can't say, well, you have capacity all the time. Okay. It has to be at a specific time. Okay. Not what sometimes in some films you find they talk about capacity, somebody lacks capacity all the time. Now, so what are the issues here? A person lacks capacity if they can't do all the following. They understand the information relevant to decision in a question. Okay. So we go to our patient, Mr. B. He understood the information. Okay, you suffer from that condition, require radiotherapy, chemotherapy, it might kill you. He has to retain that information. You have to check whether he really retained that information at the time of your assessment. So you can't just assess him for 5-10 minutes. You have to assess him for half an hour at least. Then he used the information to make their decision. And then he communicates the decision. Okay. Now, in legal terms, by the Ministry of Justice, when that number 3 use the information to make their decision, they add another one. Can he make a balance between the information? Okay. What will be his, for example, our patient here, can the information that he had is basically was given to him by a general practitioner, standing on his bedside, saying, you have multiple myeloma, we need to give you that and that and so on. Okay. And the patient is preoccupied with hallucinations, delusions, and so on, all schizophrenic symptoms. Okay. Now, can he make a valid judgment? Okay. This is always an issue. Okay. You find always when you assess capacity, you don't assess it on your own. You assess it with another, but also ask somebody else to assess it. Okay. Never make a capacity assessment on your own. Okay. Now, the important thing for the physicians, this is, okay, and for us as well, is the issue of awareness about making decisions. You do not assume if someone has in severe pain, he cannot communicate verbally, has dementia, alcohol dependence, makes a decision you disagree with, has a learning disability, has a mental disorder, is within criminal justice system, prison, and has a terminal illness, they don't have capacity. You see, this is what complicates the capacity issue. This is why British judges always say it is the worst act that has ever been introduced. And there are plans to change it. And I think it will change within the next 2 years. There are drafts for a new capacity act. So you can't say here, somebody with a mental disorder or the learning disability, okay, or you decide on them to consent for treatment or give them said treatment, not only for mental health, but also for physical health. Okay. Let's take another issue with regard to consent to treatment. This is another dilemma that faces psychiatrists everywhere. Okay, because the Royal College of Psychiatrists telling us, oh, you have to take consent of a patient. Truthfully, 50% of the patient I treat, I don't obtain their consent. I get their consent under the law from a second opinion doctor. He will sign a form for me to say you can give him the treatment you are suggesting. Okay. So this is a case of a chap, 55-year-old, he suffers from schizophrenia, was admitted to a unit for long-term care in the community. Now, he only responded to oral clozapine. Now, the psychiatrist was asked to review the case by a solicitor. So they said, look, I'm not happy about that. What he witnessed, the solicitor, was the patient being held by two members of staff, and they give him the oral medication against his will. Now, the patient is under what we call the community treatment order, okay? He has to comply, but that's in the community, okay? Now, the staff argued that, well, okay, we give him clozapine, he's enjoying life, he gets out, he goes out for a walk on the seaside every day, he doesn't abscond and have regular unescorted leave on his own. The only thing is that if you stop clozapine, right, his condition deteriorates very rapidly and you end up with psychiatric intensive care. You know, I think, of course, there are a lot of issues here. I mean, I think the psychiatrist, you know, have to make a balance of probability. I stop his medication, his quality of life will go downhill and he will end up being injected against his will. While they are holding him, opening his mouth, putting the clozapine syrup in his mouth, and he is better, okay? Yes, it might be, you know, a coercive type of treatment, but on the other hand, it's improved his quality of life. People will say, well, that's not covered by the Act. You know, the Act, you know, this is not the least restrictive practice as we are told to practice. So what is consent? The consented treatment, that you have to agree with a health professional about a treatment they have suggested for you. Well, that's an everyday life. Patient with depression, mild depression, patient with mild psychosis, you know, I mean, they will agree with you. Now, patient must give you your consent verbally or in writing to receiving that treatment, okay? In some cases, you can also give nonverbal consent, for example, holding out your arm for a blood test. So we have to obtain consent. I mean, if a patient, for example, in the United Kingdom is admitted against his will to a hospital under Section 2 or Section 3, Section 2 for assessment, 28 days, Section 3, 6 months for treatment. You have up to 3 months, you can give him treatment against his will, okay? But after 3 months, he has to sign a form called T2, okay? That is his consent to treatment. If he disagrees with you, then you ask for a second opinion doctor to come and certify the treatment you are proposing under and signs a form called T3. Okay. Another case study that I want to present to you today is about the covert administration of medicine. Now, Mrs. X is a 55-year-old who has severe rapid cycling bipolar disorder. Her condition worsens. When manic, she is severely psychotic. When depressed, she rapidly losing weight, okay? Now, the psychiatrist recommend ECT, but the ECT department declined. They thought, well, we gave her ECT, that she may get a complaint against us, and that legal issue between herself and the hospital is still going on for the last 2 years. Now, the psychiatrist suggested lithium. She refuses lithium. She was also showing some signs of early tardive dyskinesia. So what he does, he recommended covert administration of lithium. Now, covert administration in mental health is not a straightforward process, unfortunately, okay? Now, there are certain hospitals, okay, it's governed by the hospital itself. There are certain hospitals say, no, you cannot really administer treatment covertly. Now, even in the community, if the family will decide to administer patient the treatment covertly, okay, then it is what a psychiatrist will never say yes or no. I mean, just said, well, it's up to you. It's nothing to do with me. You see, you have to be careful. Why? Because medicine, people say, could be hidden in food or drink or given through a feeding tube without the knowledge or consent of the person receiving them. This means the person doesn't know they are taking a medicine. Now, that is usually easy when people have severe, physical health problem. But in psychiatry, it's a legal process. You have to go through the administration, through your legal department, inform the solicitor. There is a sign you have to fill in, and so on. Now, the code, of practice and quality care commission we have, they say, yes, you can administer medication covertly, as long as a person is actively reuses their medicine. And that person is assessed not to have the capacity to understand the consequences of their refusal. Such capacity is determined by the Mental Capacity Act, and the medicine is deemed essential to person's health and well-being. So there is a room to use covertly prescribed medication, but you find always the legal department of hospitals, all right, are not very helpful in that area. They always will make, some issues more difficult than they seem. Well, why? Because they are worried that the patient will make a complaint, and the complaint itself will go through legal route, and also that will take sometimes a year or two, and sometimes even cannot be resolved. Now, this is what I wanted to talk to you about ethical. I thought I'd keep the lecture very short. Decided only to use 3 cases. Yes, some of them may be different in different cultures, but these are the dilemma we face. I think the most important issues we carry out with us is that in my opinion, is that you be aware of the legal issues in where you practice. Also be careful and watch your juniors and watch yourself about, crossing boundaries and violating boundaries between yourself and your patient. These transference issues, I didn't want to talk about them, but maybe we'll have a chance to talk about them in the future, because some, unfortunately, people who practice mental health, sometimes they do behave badly. And thank you very much indeed.
شكرا جزيلا دكتور سداد على هذه الإضاءة الرائعة على الموضوع. هو حقيقة أنا باعتقادي من أهم المواضيع اللي لو كل يوم تكلمنا بها لا تنتهي، خصوصا بالمنطقة العربية. ليس الشيء الرئيسي هو اتباع الإثكس، الشيء الرئيسي عدم اتباع الإثكس على مستوى اليومي الفردي العيادي. مع الأسف الشديد البعض يشعر بأنه يستطيع عمل كل شيء وله الحق في أن يقرر ما يشاء، وهذا طبعا يجر إلى شيء خطير، هو تدهور ثقة المريض في الطبيب وثقة المجتمع في الأطباء بشكل عام. وأنا باعتقادي أنه الزملاء وخصوصا أو جونيور كوليجز لازم يضعوا في الاعتبار أن الإثكس مهمة. القوانين مختلفة من بلد لأخرى، ويمكن لقانون الصحة النفسية البريطاني بتعقيداته هذه ليست موجودة في معظم الدول العربية. في الأردن لدينا فقط بقانون الصحة العامة صفحة ونصف تتحدث عن compulsory admission، وهو ليس بالضرورة إن إذا المريض كان خطر على نفسه والآخرين، يكفي أن يكون حالة المريض تستوجب العلاج داخل المستشفى، وبناء على طلب الأسرة وولي الأمر وتقرير الطبيب المعالج يمكن إدخاله، ولفترات غير محددة يتم الاتفاق بين الأسرة والطبيب على الخروج. وهذه الحقيقة إحنا عملناها حتى لا نقع في تعقيدات القوانين اللي بتتطلب إجراءات كثيرة، خصوصا أنه بالمجتمع العربي ما زالت هي الأسرة هي اللي بتجيب المريض، وهي اللي بتطلب المساعدة وبتطلب الإدخال. أيضا هذا ينعكس على الممارسة اليومية، أن أفراد الأسرة يعني يريدوا أن يكون لهم دور، يعرفوا ماذا يحدث. وفي الحالات اللي يعني لنقل إذا مريض سايكوزيس أو سكيزوفرينيا بايبولر، نعطي لنفسنا حق إخبار الأسرة. لكن إذا كان مريض not psychotic, يعني we ask him to get members of his family to help. Usually we don't face a big issue in this, but definitely spreading ethics among colleagues, medical students, residents, talking about the ethical and legal issues in every case should be a standard practice for psychiatrists in the region. Dr. SUDAD, Dr. Nizar.
شكرا دكتور وليد. شكرا دكتور سداد for this beautiful lecture, very concise, informative, and updating us about what's going on in the United Kingdom. I've got quite a few comments. If it is long, please do stop me, Dr. Walid, and I will shut up after that, okay?
No, we are waiting for your comment.
I disagree with Dr. Sudad that this is a subject of less interest. In fact, it's a very interesting subject to a lot of people. And if you go to the or let's say if you speak with the junior doctors and tell them what they think about the practice of psychiatry, especially that practiced by the senior doctors, and of course if you give them the chance, تعطيهم الأمان, give them the chance to talk, so they will tell you a lot of problems that they see in their daily practice, which really needs discussion, but they are just left like that. That's one. The second thing, I quite agree with you when the title was ethics in clinical psychiatry, because really you have to divide the ethics in psychiatry into two, classify them into ethics in academic psychiatry, which includes many other issues related to research and other ethical things, and also ethics in clinical psychiatry, which are related to what you mentioned. By the way, next November, at the end of November, there is a conference in Baghdad for the Iraqi Psychiatric Association. I will give a talk about mental health ethics in that conference. Another thing is one of the problems that we face with our, let's say, Iraqi people who are living in the West, especially the refugees and those who are no more refugees, they became citizens, like let's say, especially in Scandinavian countries. They don't treat patients if the patient refuses the treatment, and the families are concerned about that because the families are still having the culture of the, let's say, Iraqi culture. So what they do is they bring them back to our country, and we have to treat them in the Iraqi way, as Dr. Walid said, on the request of the family. And of course, sometimes it works very well, but sometimes it doesn't. Most of the times it works, but when the patient goes back to the West and he stops his medications, of course, the problem comes back again. The subject of confidentiality, I will give you a good example that we face almost daily. A family comes with either their son or their daughter. First, the father and mother enters the room. They tell you that we have our son with us or our daughter who's ill, and he or she has this and that. He will enter the room, and please give him a chance to talk whatever he says. I said, okay. But later on, when he leaves the room, they come in again and they will ask you, what did he say? So this is a daily conflict that we really face. Sometimes when the subject is very serious, especially when there's a risk of suicide or self-harm or these things, sometimes you have to tell them, but most of the time you cannot. But they will tell you, so why did we bring this son or this daughter to you? We want you to tell us about him. So this is a daily problem that we are facing, really. And the same applies for suicidality. Sometimes the patient comes to you, and I think we spoke about this subject in these series of Zoom meetings. A young person comes to you, borderline personality disorder or any other type, and who is really suicidal, not only self-harm, and you don't know what you do with this case. I mean, who would you contact? Most of the time you don't have a number to call, or we don't have a GP system, we don't have social workers. So that's another problem that we face, really. And another thing is the family sometimes bring a patient and they'll tell you, don't tell him what's wrong with him. Don't tell him anything that you are suffering from a psychiatric disorder.
Don't tell him that you are a psychiatrist.
Yes, don't tell him you are a psychiatrist. We brought him to you because he says he has leg pain, or let's say something like that. That's one thing. Another thing that I would like to really stress for our junior doctors and, of course, for our colleagues is the difference between professionalism, very meticulously, Dr. SUDAD referred to it, and occupation or vocation. The difference is that in professions, you have certain rules and regulations and certain ethical principles that you have to follow. But in a vocation or in a job, you don't have that. I'll give you an example. In 1983, when I started practicing psychiatry in Erbil, one of the cities in the north of Iraq, in Kurdistan region, I was almost the only qualified psychiatrist in the region. And at that time, I was charging each patient, let's say, 5 or 6 dinars for each Iraqi dinar at that time, for each consultation. Now, there were merchants in that town selling spare parts of cars or selling other things. If that merchant knows that he is the only merchant in the town who sells these spare parts, he will really charge people 10 times the price. This is the difference between a professional and somebody who has a job or a vacation, and that applies to a mechanic and to other professions. That's one thing that really I wanted to stress, because we have to train our junior doctors that they should follow these principles rather than the al-ard wa talab or whatever it is in the market. As far as the Mental Health Act is concerned, we have also, just like Dr. Walid said, Qanun al-Sahha al-Aqliya. We have 2 types, one of them in Iraq, the federal government. It has been approved by the parliament, and we have another one in our, let's say, region, Kurdistan region, also approved by the parliament, but we cannot implement it because there are no, the infrastructure to apply these things is not available there. And if we decide to implement it, then all of us, the doctors, the psychiatrists, will be in jail. Every day they can take us to court and they can put us in prison. So it is there, but unfortunately, we cannot really implement it. As far as the mental capacity, I just wanted to refer that sometimes it's not an all or none phenomena. For example, in demented people, in people who are elderly, and if you want, let's say, he is rich, he has money, or he has certain resources, we will not say that he is not capable or he hasn't got the capacity to spend his money, and you give the, let's say, power of attorney to his sons or his daughters, and they will prevent him from spending this money, and they will spend it for themselves, and they will not take him to a doctor for treatment. بالعراق نقول يصرفها يسويها خردة. You could say that he is he has no capacity for this issue, but he has a capacity for another issue. So it's not an all or none phenomena. And I understand even in the United Kingdom now, they will decide capacity for specific issue in the behavior.
Of course, yeah, this is the issue. I mean, as I stated, I mean, capacity is specific time, is specific decision. Yeah.
Yes. Yes, yes. As far as the covert administration, this is very new to me. By the way, the words overt and covert are intelligence words. I mean, used by the CIA and other intelligence agencies. We follow I mean, we don't follow, but in Iraq, a lot of families give their patients the drugs, they put it in the food, and it depends on the type of the food and the taste of the food and so on. So we do that, but I didn't know that the same thing is done in the United Kingdom. This is new, very new to me, but I do the same. I tell them, I don't know, it's up to you, especially those tablets that they dissolve very quickly in the food. So that's one thing which is good. One thing that was not related to me, it's very, very important, and it's really a big dilemma, is when you are practicing in a place and there is, let's say, another person practicing next door to you, next door to your clinic, also a psychiatrist, or he is in the hospital with you in places like the National Health Service where there are no, let's say, I mean, most of the people are not in the private clinic, they are in the National Health Service, and this person malpractices, or he exploits patients, or he gives a lot of medications to patients after making deals with the drug companies and so on. This is one of the really great challenges that we face daily, and I face these things every day, and sometimes you cannot just wait like that. I mean, as they say, but when you talk, you will be in trouble. Why? Because in places where the number of psychiatrists are limited, then even if the psychiatrist is, let's say, punished, or let's say is defamed, then one day comes that this person will become a responsible person, and you will be in trouble dealing with him. So this is one of the challenges that I face daily. I'm sorry I spoke a lot. Thank you very much for listening to me.
No, this is very interesting. Thank you very much. And actually, you were right. I mean, I'll give you an example. I mean, recently of a lady who is, you know, I mean, yes, she's from a rich Arab family and so on. And she goes to a psychiatrist. I mean, all of a sudden, she ends up on massive doses of gabapentin. All right, we are talking about something 4,000 milligram daily, plus, you know, massive amount of lorazepam, and then on top of that, he give her TMS daily and so on. To the point really become, you know, that was a malpractice, but, and then she end up in Switzerland when all these things have to be, you know, it's a question is, would you inform about him or not? I mean, you see, because you're talking about your next door. But also, I think sometimes, you know, when you find your colleague is misbehaving about certain things and so on, communicating with patients and so on. It's all of the ethical dilemma that we face as us. And I think what is important, I always say it's important when you have your junior doctors, you have to supervise them, okay? Just make sure that they have their hours supervision weekly, just to make sure. But I said, I mean, it's a dilemma sometimes when you see some practices that are, you know, very, very difficult to justify. And what do you do? You know, would you inform? Would you not? I mean, but sometimes, I mean, if you, for example, I mean, if you notice your colleague coming to work and smelling of alcohol, I don't think any one of us will hesitate on informing the management about it. Mm-hmm. You see, I mean, that's really something you have to do. You know, I mean, you know, some of your colleague is taking drugs, you know, but, you know, or alcohol, I think you have immediately to inform of them so that they can get the help, especially as you know, alcohol problems are not uncommon among the medical profession and psychiatrists. Thank you very much, Dr. Nazar. It's very, very informative.
Thank you.
دكتورة جنان تسأل is oral disintegrating tablet ODT considered covert medicine?
No, not really. It's not covert,
Yeah.
But I think
things like the risperidone syrup that is tasteless, colorless, that is typically the one that patients are taking without knowing. And
yes, I think so.
It's acceptable to use it for like patient needs sedation to be hospitalized, things like that, for a day or two. It's something I sometimes do, but to give it forever as oral hidden syrup, this is very, very difficult. And yes, many patients come to tell me, I was sick, but I'm all right now, and I'm not taking medication. And the family has already told me they are giving him 12 milligram risperidone syrup daily. And how would you convince him that he is in need of medication? He's in full remission. And what happened actually, usually the mothers are doing this. And once the mother died or is sick or old, the whole family break down. Nobody can give it to him. He would realize nobody's living with the patient. These things has to be taken on a long term. Okay, if somebody in need today and he's been given risperidone syrup, that's just for today. Now he's hospitalized and compulsorily and so on. You cannot carry on to do this forever, but we do. I have seen patients who've been on hidden medication for 20 years.
Yeah. Now this happened. I mean, I have a chap I know from Kurdistan, and his father has a problem and so on. And, there's something about him. To be honest with you, the only treatment that helped him was haloperidol syrup. I know what is good about haloperidol syrup. It's tasteless. You can mix it with anything. And, and I have to admit, I did prescribe the medication. He comes, they prescribe it, take it over there. I said to him, do you have to, go and see somebody in Erbil and so on? I said, this is not, but what do you do? I mean, that's a treatment he has, that his quality of life is better. They keep on giving it to him for years and years, Sometimes we all have.
Yeah, I have a similar patient who has been on olanzapine for at least 15 years, and he's 10 milligrams daily only at night. They put it in the food. Usually the main meal for some people is at night rather than in the lunchtime. And he is happy, the family are happy. And to answer Dr. Walid's question, the daughter will take over the role of the mother if the mother dies or she is not there. Because they are very close to the patient. Of course, his brother or his father will not take that responsibility.
Okay, أي أسئلة من الحضور الكرام؟ تمام. شكرا جزيلا دكتور سداد على المحاضرة الرائعة، ونلتقي بعد أسبوعين إن شاء الله في محاضرة جديدة. تصبحون على خير.
شكرا جزيلا على دعوتكم. شكرا.